Three because they were, very, very poor in terms of the methodological design of them. And one because it was done by an anonymous author, so obviously we weren't able to determine any conflict of interest there, which is really important. So in the end, we had 19 randomised controlled trials. I said earlier on that TENS is usually applied to the back, and in our studies there were 15, but there were 2 that had TENS applied to acupuncture points, and 2 TENS applied to the cranium, and that's something which happens in other parts of Europe. And our 2 main outcomes were pain intensity in labour and satisfaction with pain relief. We thought that the second of our primary outcomes was really important because I don't think that you can just look at pain per se. It's the woman's ability to be able to cope with that pain, so it's how she perceives her pain management. We also had a number of secondary outcomes, and here you can see a list of the maternal outcomes. And when you do a review, what you do is you dictate what outcomes you want to find. It doesn't necessarily mean that you are going to find those outcomes in the papers that you have retrieved, but these were the things that our team thought were really important. And also we wanted a number of neonatal outcomes, APGAR score, core pH and adverse events as defined by the trial authors. So, what did we find? I'm not sure whether you're all familiar with this type of chart, so I am going to try and talk you through it, but this is the usual way that results of systematic reviews are presented in what we call a meta-analysis, which is when we pool together the results of more than one trial. Now I don't have a pointer, but I'm going to try and do it with the mouse if I can. So, where's it gone? Lost my mouse. Okay, so we looked at severe pain in labour, which was one of our outcomes. And in this study, we were looking at TENS to the back in this meta-analysis, but I'm going to keep losing this. Ooh. I don't think I'm going to try doing that. I'll just have to try and talk you through. On the left-hand side, you will see that there were just 2 studies, one by Bunsen and one by Harrison. You can see that they were quite old studies, 1982, 1986, and you can see that they were very small studies as well. So you can see in the first column of numbers, this was a TENS group, and the number that reported severe pain in labour was 3 in the first study and 38 in the second. And then you can see that we've merged the placebo and the routine care in the next part. But the most important way to actually interpret these type of results is to look at the actual graph where you see the shapes. So you can see along the right-hand side in the top row, you can see a black line, which is confidence intervals, and then you can see the risk ratio. Now, the important thing to know about these charts is that the pooled result is the diamond shape at the bottom. So that black diamond shape is the pooled result of those 2 studies. Now, if that result crosses the line, crosses over the 1, it means that there isn't a statistically significant result. Now, in this one, you can see in the bottom figure, in the subtotals, I will try and get this one without it moving. So it's that one there. You can see that the confidence interval is 0.6 to 1. So it's almost significant, which you shouldn't really say, but there is a trend towards favouring TENS, but it isn't statistically significant. And we would throw caution if we were looking at these kind of results, especially because it is such small sizes. So we can't say for definite whether TENS does actually reduce pain in labour. If we look at pharmacological analgesia use, And again, the left-hand side of the chart favours TENS and the right-hand side favours placebo or routine. And again, it crosses over the line, the amalgamated shape at the bottom, the merge of all the different results of the studies. So there doesn't seem to be any difference in pharmacological analgesia use. Then if we look at epidural use, you can see that we included 5 studies in this. And again, the left-hand side favours the TENS. And you can see it crossed right over that line, and there doesn't seem to be any difference. So then if we look at vaginal birth, and there was a few more studies that had this as an outcome measure, and there was 8 studies. And again, the pooled result showed that there was no difference. The next one, satisfaction with pain relief. I don't know why, but for some reason this time the favours TENS is on the right-hand side, just to confuse you. But again, it does actually cross the line. The confidence intervals go across the one, so therefore there's no difference. But then we look at this one, and we had 4 studies that we amalgamated in this result. And would you use TENS again? And you can see here clearly that the pooled results don't cross the line, and it does favour the TENS. So more women in the TENS group would like that form of pain relief again than those who are in the other group. So I hope that makes sense to you, but I will summarise it. So the conclusion of our review was that we felt that actually the results were pretty inconclusive. The reason why we said that is because the available evidence was very, very weak. It was inconsistent, and it was really, really difficult to interpret. We felt that there was some evidence, albeit very, very weak, that women using TENS are less likely to rate their pain as severe. But importantly, we found that the majority of women in these studies were willing to use TENS in future labours, and that has got to be an important outcome. But there was no evidence that TENS has any impact on outcomes. So I just want to remind you of my initial slides in terms of that, it should be fit for purpose. It should be doing what it's set out to do. So in some ways it makes you perhaps start to question its use. But there was no evidence of any side effects, so there was no evidence of any harm. And women did appear to like it. So just bring you back to the NICE guidelines, and we said that TENS should not be offered to women in established labour. And I think that's the bit that we need to focus on, because every single study that was included and every single study that's been done had introduced TENS when the women were already in active labour. So they weren't introduced until the woman actually came into hospital. They were all studies done in the hospital, so the women were all in fairly advanced labour. So I personally think that is a major flaw of these studies. We were unable to access some important outcomes in terms of neonatal outcomes, the sense of control in labour, the overall satisfaction with the childbirth experience, cervical dilatation on admission, or at least on when they started using the TENS. The quality of the evidence, well, it was a small sample, and even though the sample may seem large, 1,671, when we broke it down into the outcomes, you'd see that, that few studies had many outcomes, and therefore when we pooled the results, the overall results for each outcome was pretty weak. There was the risk of bias was generally very, very high in terms of the allocation to the particular group, in terms of the blinding, and in terms of the follow-up data. So there's a lot of incomplete outcome data on these studies. The outcome measures differed between the studies. So it differed in terms of how they actually, for example, measured pain, how they measured satisfaction, when they actually measured the pain or the satisfaction, and who actually measured the pain or the satisfaction, because in some of these studies it was actually the midwife that made her assessment of the pain or the satisfaction. It wasn't actually the woman who was in labour. So you can see that there were so many problems. Also, the care that was provided in these actual trials was so different. So in many ways, it was like mixing apples and pears, which is one of the pitfalls when you do a meta-analysis, is that sometimes you are actually bringing together studies that have totally different contexts. So you do have to acknowledge this. So the overall conclusion and implications is that the current evidence base is very limited. But women and midwives are continuing to promote the use of TENS. And I actually think that we do need a robust randomised control trial so we can give, truly informed evidence-based information. I said I would return to the quote that I put at the beginning, and I'll give you the whole quote now. This was the title of the piece. It said, "There's little evidence supporting the use of TENS during labour." You can tell it was an American, it's an American group, but does that mean it shouldn't be recommended? And then they went on to say that researchers from the University of Manchester in the UK come to a bewildering conclusion. The UK NICE recommends that TENS should not be offered to women in labour. Probably that's because it's a procedure that has no impact on the process of giving birth or outcomes. Despite this, the authors concluded, given the absence of adverse effects and the limited evidence base, it seems unreasonable to deny women that choice. More robust studies of effectiveness are needed. In the absence of sound evidence that the practice might make a positive difference, isn't there enough to do during labour and delivery without adding to the confusion by sticking little electrodes on the skin? So I'd just like to ask you again now, after giving you that evidence and giving you time to think about it, and thinking back to what I said about it should be fit for purpose, do you think our conclusion was right, or do you support the views of the CAM report? And I'm not going to do another show of hands. But over coffee, perhaps you may want to come and tell me what you think. And I think that in any type of intervention, it's quite difficult because once something's already been introduced, it's so difficult to remove it. If we could turn the clock backwards, we would have done the research before it was introduced, like many things in maternity care. Thank you very much.